Thank you very much. Well, I've been asked to talk about zoonotic disease and public health in Africa, which is what I've been doing really for the past 20 odd years. But I originally started my career at the Tsetse Research Laboratory, so I worked on tsetse flies, human sleeping sickness, and anopheles. But sort of branched out in the last sort of 10 years to look at the other neglected zoonoses. And I like this slide, this photograph of these children in a village in Uganda, partly because this little boy is wearing a lovely little, what we would say, I suppose, a girl's pink t-shirt, which is from a very well-known brand of clothing for fashionable young people. And it always astonishes me that we can't get any health services to these people, but we can actually get designer t-shirts into these communities. And I think it's something that we need to think about as we go through this talk. We can't talk about the neglected zoonotic diseases really without talking about the Millennium Development Goals, because this has dictated funding and support for research and outreach and translational activities for the neglected zoonoses and the zoonotic neglected tropical diseases over the last decade. And we really fall under MDG 6 to combat HIV, AIDS, malaria and the other diseases. And again we come under Goal 6, where by 2015 we're going to combat HIV, AIDS, malaria and these other diseases, whatever these other diseases may be. So target 7 is to halt and begin to reverse the spread of HIV, AIDS, which we're not going to meet by 2015. And target 8 is to halt and begin to reverse the incidence of malaria, which we're probably not going to meet, but we might actually be able to make some sort of inroad into this sort of vague other diseases here. So what are these other diseases? Well, the problem is the other diseases are a whole bunch of everything that they forgot to put in the first place, including disease, pandemic, risk, diarrheal diseases, acute respiratory infections, plague, dengue, these NTDs, of which the neglected zoonotic diseases come into. So the neglected tropical diseases, which is the sort of overarching header for the neglected zoonotic diseases, are a whole range of protozoan, helminth, viral and bacterial infections. And they are the most common afflictions of humankind. And about half of the neglected tropical diseases are actually zoonotic, these ones that are in pink. But very little has been done to address the fact that these diseases are transmitted between poor people and animals in these systems. They affect the world's poorest people, 2.6 billion people who are subsisting on less than $2 a day. But any intervention can have a considerable impact on not only MDG 6, but a lot of the other MDGs as well. And the neglected zoonotic diseases, along with the neglected tropical diseases, promote poverty. They stigmatise people, they disable and inhibit people from being able to care for themselves and their families. And their distribution is about 50% globally in South Asia and 30% in Africa. And if we have a look at the global distribution, as always, Africa's a winner on this one, unfortunately. And if we have a look at world hunger, of course, these tropical diseases and neglected zoonotic diseases are at the same place as we see hunger. So we've got these extreme problems. More than 70% of the countries affected by these neglected diseases are low-income, middle-income countries, and 100% of these low-income countries are affected by at least 5 of these neglected tropical diseases, of which approximately 50% would be the neglected zoonotic diseases moving between people and domestic wild animals. So why are they neglected? Well, neglect is a consequence, in terms of disease control, is an unintended consequence of this system of prioritisation of health in health economics. So funding, while logical, isn't fair, and it's not fair or sensible, but that's the way of the world. And the problem really is that everything is based on these DALYs, which are a time-based measure that adds together the years of life lost owing to premature mortality with an equivalent number of years of life lived with a disability or illness. And the WHO Global Burden of Disease Project pulls together all of the data, a lot of which is really quite unreliable, and creates this sort of table of DALYs. And of course, this results in AIDS, TB, and malaria monopolising the global health agenda. And donors consult these tables and make their decisions about how they're going to spend their budget and their money. And you can see why they're spending their money on HIV, malaria, and TB because of the DALY score. Again, these lower respiratory infections, diarrheal diseases, neonatal infections, prematurity, and low birth weight. You can see why donors do what they do, and actually you can't complain about them doing what they do. It's the right thing to do in a lot of ways, just not right for poor people suffering from zoonotic and neglected diseases in Africa. And the big three do cause 23.5% of the disease burden. So it's really an unintended consequence of funding that's going towards the big three. And we have to remember that they haven't got enough money either. It's not that all the money is going to AIDS, TB and malaria. There's not enough money, as we've seen, in terms of meeting our targets for 2015, even to meet those targets. So what are these other diseases? Well, they affect several hundred million people. They kill at least 500,000 in Africa, annually, most in Africa. And they do attract very little attention. And the main problem is that this Global Burden of Disease project underestimates the burden of tropical diseases. And this is because we don't have reliable data going into that. We don't have reliable diagnostics. We don't have health systems which actually are recording these diseases. So we can never win in terms of correct representation of these diseases. But in terms of their contribution, they contribute still a significant number towards the DALY burden, 24% of the neglected of the infectious disease DALY burden globally. And if we have a look at the correlation between DALYs and R&D funding, you can see that it does impact. The NTDs get less than $1 per DALY spent, whereas diabetes, cardiovascular, AIDS are all quite proportionally well supported. Well, what they do offer us, these neglected tropical diseases, is tremendously good value for money. And if you adopt a cost-benefit approach, such as proposed by Camel, then you can actually make some different arguments about why these diseases and other conditions should be prioritised in Africa, based on the fact that actually they're very cheap to deal with, and the cost-benefit ratio is extremely high. And a lot of these health interventions across the board in low-income countries can have tremendously high cost-benefit ratios. And if you look at it in this way, then you can actually have a look at interventions against these diseases as investments. And this is a new way of thinking about fundraising or mobilising support and advocacy for these diseases, to not put them in the sort of bless category, you must give us some funding and support, but to say this is a really good, sensible, strong investment if you do this in the system. And we'll come back to that at the end of the talk. So the neglected zoonotic diseases, or the forgotten diseases as we tend to refer to them now, we have to remember that at least 61% of all human pathogens are zoonotic. 75% of all emerging pathogens over the last 10 years have arisen from a zoonotic animal base. Except for the newly emerging zoonoses, most of them are not prioritised at health system at national or international level. And they don't actually, so these neglected zoonotic diseases don't only have to compete for any funding that's available in country with the big three, but they have to compete also with the emerging zoonoses, SARS, avian influenza type diseases, and also with the neglected tropical diseases that are very amenable to mass drug administration, like the schistosomiasis and the filariasis control programs that have mobilised a lot of support. You can't really get around politics when you're dealing with neglected tropical diseases and zoonotic diseases, and this is particularly acute for the neglected zoonotic diseases, because you can see how the pharmaceutical companies and governments jumped to with a zoonotic disease, a false zoonotic disease, swine flu, a few years ago. Huge investments, huge money was put in that because it was a threat to us in Europe. Trade and industrial interests, there's not enough money really in the diagnostics or the treatments that offer good returns on investment from industry to invest, and the lack of threat. So to some extent the non-zoonotic NTDs are amenable to MDA, and you can see that Pfizer and the large drug companies are giving drugs in order to raise their profile globally, to give some drugs for support for that. But mostly there's not enough money in it for that. And 0.6% of our overseas development aid for health is allocated to neglected tropical diseases, despite these diseases affecting at least 1 billion people. But less than 10% of that actually goes to these neglected zoonotic diseases, which represent half of the total burden. So what are they? Well, we're talking about brucellosis, canococcosis, rabies, leishmaniasis, cysticercosis, bovine TB, and trypanosomiasis. And the biggest burden, of course, of this lies in the African continent, which has an open list of these NTDs. They do have a considerably high burden. They do contribute a lot of the DALY burden within the neglected tropical diseases, but again, the lion's share of the funding and finance now goes into lymphatic filariasis because of mobilisation of DFID and other donors into this MDA programme. And if we have a look at the impacts in terms of the other emerging diseases, you can see Nipah, avian influenza, and SARS, very few human deaths a year when compared to rabies. But you can see the interest from this enormous economic interest in dealing with these diseases. So again, our annual deaths, but we don't really know how many annual deaths there are, at least 500,000 deaths. And the ones in pink again are the zoonotic diseases. So half of the death burden is contributed to this. So really these neglected zoonoses are endemic diseases of poverty. They're an unintended consequence of a system of prioritisation. Our evidence base is really poor. We can't really show and define the burden of the diseases because we don't have the systems in place for the simple diagnostics and cost-effective diagnostics. And a big problem comes from the division of responsibility for these diseases between the medical and veterinary sectors, and this is a barrier to sustainable control. For 20 years, we've been trying to deal with sleeping sickness in UGANDA, which is the Zoonoses. If you go to the Ministry of Health, they say, we're not going to give you any money to treat animals because it's out of our health budget. You go to the Ministry of Agriculture, they'll say you can't have any money because the impacts and the consequences of the infection are on people. It's the same with rabies. Somebody's always arguing about who's going to pay for this vaccination and who's going to pay for the administration of any to them. Privatisation of veterinary services across Africa has had a major impact because nobody's actually on the ground now to do anything about any of these diseases. And these zoonotic diseases, the control and surveillance just falls between the cracks in this. And really what it's saying is that there's no, it's massive failings in community public health. We don't have any community public health functioning. The underestimation of disease burden is inevitable because we're using extrapolation. I mean, it's a big, big place, and we're using extrapolation of scant data. And we know that in Uganda, from work that we've done and that Christine's done in this room here, a PhD, is that for every death reported, at least 12 deaths are unreported. And using more and more sophisticated molecular tools, we're finding more and more people infected. But for most of the neglected tropical diseases, and certainly for the zoonotic diseases, we just don't know what these numbers are. So they do offer us challenges, but they offer us opportunities. They do offer the opportunity in the current climate to link people, animals, and environment. We can, for many of the neglected zoonoses, appropriate interventions may exist, but they just can't be implemented because the benefits haven't been made clear to the sector, so either to the medical sector, the private sector, or public sector. But following the success of these mass drug administration campaigns, both politically and internationally, we could look at interventions for these neglected zoonoses that unlock these multiple benefits. We can transform these weaknesses into strengths. Often these diseases are geographically clustered, in which case they're cheaper to control. They're underreported, so actually, if you can control them, the benefits are much higher than you would have thought. We have to control it in people and animals, so you can offer more options for control. And these dual costs should be able to bring dual benefits. So what are their characteristics? Well, they selectively affect poor families in poor and marginalised communities. They have an illusion of low incidence. Diseases can cluster in certain communities, and you can identify certain risk factors in certain communities for some of these diseases. They impose a dual burden on human and animal, mainly livestock health, but also on wildlife. In wildlife zones, they can have a wildlife revenue. A lot can be achieved by health education and control of the animal reservoir, but health education sounds very easy, but it's actually very expensive and difficult to implement. And we can have these high cost-benefit returns. And can we quantify this total societal cost so we can actually evaluate it and put a value on the savings? Well, we can quantify disease burden using DALYs for people and looking at economic impacts for livestock. We can identify at-risk groups. These may be individual factors for people, animals, geographical or poverty factors. And we can get a much better angle on estimating incidents, survey better reporting, estimates and underreporting. And this is where sort of good tools and diagnostics come in, because if you haven't got the tools to measure that, you're really lost before you start it. And this is a project that I've been running for the last sort of 4 years now, which is integrated control of neglected zoonoses, which is improving human health and animal production through scientific innovation and chronic engagement. It's a €6.5 million project that I manage. And what we're trying to do is build the evidence base in Africa for the zoonotic diseases and put a value on underreporting and cost effectiveness. And if we can, deliver a One Health solution or solutions which actually demand the integrated response of both the medical and the veterinary professions. And if you sort of have to sum it up really, it's asking, you know, who's going to benefit from this, how much are they going to benefit, and who's going to pay for it. We have case studies in Uganda, Mozambique, Nigeria, Mali, Morocco, Tanzania and Zambia, and we're looking at anthrax, rabies, leishmaniasis, chynococcosis, zoonotic trips, brucellosis, cysticosis and bovine TB. We have teams involving medics, vets, biomedical scientists, social scientists, anthropologists and economists, and in-country partnerships with the relevant ministerial agencies, plus engagement with civil society and NGOs. What we're doing is we're trying out different approaches for zoonotic control that might add value or build value in these communities, and hopefully obtaining these models for case studies that can be extended and applied to broader and wider systems. Really, what we have done, because of the constraints of the project, is looking for practical ways of combining existing measures and funding and agencies and bringing it together. Because for a lot of these things, we don't need anything new. Having something new and more effective would be great, but in the absence of something new, we should be getting on with it, which is what's happened for the neglected tropical diseases. So, what could these look like? Well, originally we thought, well, why don't we look at them in terms of bacterial interventions? So for TB, anthrax, and brucellosis, they're all bacterial diseases. They should all share some sort of platform, either in the delivery of control or in terms of surveillance. And unfortunately, this turned out to be not such a great idea, because we thought that we could go into the community and do surveillance for TB, bovine TB, and for brucellosis together. But unfortunately, the diagnostic tools that we have aren't practicable to enable that. If we had a single pen-side diagnostic, where we could go in and actually get a result on the day, then you could do that. But with the tools that we've got at the moment, it's not practical to go in and do both things at once. Because for TB testing, you've got to go back. You can actually get a result on the day for brucellosis, but you can't for TB, so it always requires another visit. And then there are arguments about who's going to pay for this subsequent visit. Anthrax is an outbreak disease, so it doesn't fit in that profile. But it sounded like a good idea at the front end. And in fact, last week I reviewed some grant applications where other people have thought about this, and I didn't like to say, well, it's not going to work. It does sound like a good idea, but it's not going to work. Because we don't have the tools at the moment that's going to make that practical. The other problem is what do you do with brucellosis? We've dealt with it here because we've boiled milk and we've had a vaccination and a cull program. You can't cull animals in African communities. It's not an acceptable practice. So what's the point in diagnosing bovine TB in an animal when you actually can't cull and you can't offer compensation? So there are all sorts of difficult issues with that. But what we can do with brucellosis is we can, at 10 cents a pop, vaccinate animals with an S19, which is a very old vaccination that's been on the books for a long time, which can actually be administered from eye drops in communities which are at risk. So a more sensible strategy is to look for communities at risk and implement a vaccination strategy which is actually cost effective and could actually be undertaken by communities. The problem is that you can't give this vaccination to animals that are pregnant. And in communities in Africa, it's very difficult to tell which animals within that herd are actually in calf, because you've got intact bulls roaming around, so it's difficult, but not unsurmountable. Another thing that we've been trying is what we do with dogs. They're a target organism, and dogs, of course, are presenting the sort of lion's share or the reservoir for most of the rabies burden across Asia and Africa. And it's very expensive, the post-exposure vaccination. So can we roll out vaccination for dogs? And at the same time, can we deal with the echinococcus as well? Because the dogs are actually transmitting echinococcus and rabies in these communities. So can we do something which actually targets the dog? In areas where you've got rabies, echinococcosis and leishmaniasis, can you do something which actually targets all three diseases? For example, can you vaccinate the dog against rabies? Can you sterilise that animal in order to have dog control? Can you deworm the dog in order to have an impact on echinococcosis? And can you put an insecticidal dog collar on that dog in order to stop transmission of leishmaniasis? And this is what we're trying in Morocco at the moment. Of course, you have to have communication and messaging. Of course, you have to have effective veterinary public health in the slaughterhouse to stop the dogs taking the offal and increasing the transmission cycle. It's all very difficult, but it's all real, solid veterinary public health work. Then we thought, what can we do about pigs? Because as most of people will know, pigs are regarded as a very cheap, quick protein source in Africa. Pig rearing in non-Muslim communities is becoming a really popular activity. But of course, pigs bring with them a big burden of teniasis and cysticercosis. Massive problem with cysticercosis and neurocysticercosis. A lot of communities now suffering from epilepsy. We don't know if this is natural epilepsy in that community or whether this is being built on from the cysts in the brain. And here's a very nice pig here who's just been to the latrine. His breakfast. Shouldn't really mention that at a breakfast meeting, but that's why pigs are kept in communities in Africa, because they do require zero inputs. They don't need feeding because they'll do their job quite effectively and eat stools. So what could we do for that? Well, the pig intervention package that we're looking at is actually looking at some development, big development issue, which is this community-led total sanitation. There's a guy called Camel, who's a real sort of messiah, who is promoting an interesting combination of quite aggressive community measures in order to stop people defecating outside of the latrine in the community. And basically it's a program of facing people up about all of the shit in the village. And they go around the village and they put coloured paint on all of the stools that they find around the village, and it just exposes the communities to how much shit they're living with in their environment. But of course, if you can stop people shitting in the village and have latrines, then the pigs don't have anything to feed on, and you can actually break the cycle of infection with cysticercosis as well, plus have an impact on soil-transmitted hazards in the community. So in Zambia, we're looking at the impact of community-led central sanitation, and in Mozambique, we're looking at a putative vaccine that's been developed. So we're comparing these two things to see which would make sense. The problem with the vaccine is you've got to, at the moment, the vaccine that we have in development, you'd have to give the piglets 2 or 3 vaccinations, and it's a zero input commodity. So A, nobody's going to pay for this vaccination, and B, the cost of actually getting that vaccination to the community 3 times to vaccinate those pigs are going to outweigh probably the life of that pig by the time you've got somebody out there. And then we've got our vector intervention package for sleeping sickness. Everything in the community, in animal health terms, is geared to this little creature here. This is the holy grail for most smallholder families. This very precious calf that might take 4 or 5 years to come. It might be the only calf that your cow has, and everything's geared to the preservation of this little animal. And the problems with this little animal is that it can get human trypanosomiasis, animal trypanosomiasis, it can get human trypanosomiasis, and it can get tick-borne diseases. So if we can actually stop ticks and tsetse from getting onto this animal and prevent this infection transmitting over into humans, then we're doing quite well. So what we have is we've been trialling an intervention treatment where we eliminate the infection of human parasites in the animal reservoir. So we treat all of the animals with a very cheap trypanocidal drug, and then we put insecticide just on the belly and the legs of the animals where the tsetse flies bite. And this doesn't interfere with the endemic stability of the tick-borne diseases, and has big impacts. And if you can do this every month, Dennis is doing this for his PhD at the moment. We're doing a trial to see how many animals actually need to be treated with insecticide in order to stop transmission in the village. And I think we're down to 15%, or 20%, Dennis?
Around 25.
About 25% of the animals. So it's not very many animals need to be treated every month in order to have that impact. So if we have a look at our combined societal and economic viewpoint, we've got all of these factors, we've got our control costs and our control benefits, and these cost-benefit return is absolutely the basis on which government, donors and NGOs should allocate and do allocate resources. And really what we're talking about is one public health, what you will hear in the literature called One Health now. It's a sort of new buzzword that's going around, which really means one public health. And again, this seeks to shift this paradigm from an individual or disease-centred approach to a community-based approach. It's moving systems in country from crisis response to strengthening systems to deal with risks and endemic disease. And this integrated control can actually act as a sort of leverage and a really good encouragement to get to work with the private sector. And the tripartite, which is WHO, FAO and OIE, are now embracing this One Health concept and proposing this for rabies and FMD in order to mobilise human and animal systems in order to put stuff both into research and development and into action. So if we have a look for sleeping sickness, which is very close to my heart, most of you know. If we have a look at the cost effectiveness of targeting these interventions at cattle for human sleeping sickness, we can avert epidemics and we can contain disease. And we can probably push disease into elimination. We've got human health benefits in Uganda of between 100 and 400 million and animal health benefits of about 60 million a year just by doing a very simple intervention. And these are very persuasive arguments for government. So what can we do next? We've got proof of concept. We've been doing this in 9 districts of Uganda, and now we're going to roll this out to 37 districts of Uganda, where 9 million people are at risk of contracting sleeping sickness. And this is going to need mass treatment of about 2.7 million head of cattle. And the nice thing for us as implementers or as proposers of this method is that 9 districts account for 80% of the cases reported over the last 25 years and the last 4 years. So this is again, you've actually got areas where you can actually concentrate your efforts and then spread out. So you've actually got the ability to sort of roll out and target your interventions to where they're most needed. So what we're proposing at the moment is a 3-year mass vaccination program to quickly reduce and sustain parasite prevalence in cattle. And then this will be supported by establishment of a private sector veterinary network in order to deliver veterinary care to these communities, not just to visitors across, but also to deliver these insecticide treatments and maintain this impact. Our targets are 85% of the cattle in the target areas. The treatment will be free of charge for farmers. We've got to have some active promotion of health messaging. There's a lot of work setting up all of this infrastructure for this programme. So it's a long-term programme, and this is a problem in terms of funding because this outlives a government cycle. That's always a problem. We're talking about something that's going to take 8 years now. And it's the same if you think with rabies. You need to have a sustained pressure on something for a long time in order to have the impacts. Rabies is a particularly good example. Everybody knows we should do something about rabies, but rabies vaccinations are only administered to dogs if there's no other veterinary problem in the country that year and there's a bit of spare money. And then the next year, that's not sustained, so all of the benefits that you accrued in the year that you did vaccinate the dogs and sterilise the dogs is lost as soon as the next crop of dogs is born. So who's going to pay for this? And this is where it becomes quite interesting for me, because this brings me into the world of the City of London, which was somewhere that I never thought that I would be working. And basically implementing these interventions at such a scale requires upfront loading of expenditure to deliver impact. And this is where all development problems have a problem, because it costs a lot of money to set it up. And it would be the same with the rabies vaccine. You'd have to set up vaccine banks. Nobody wants to pay for that infrastructural big push at the beginning to get it done. And this implementation this upfront funding in our scenario is provided by private investors who are going to bear the risk of this success. And again, implementation at scale is logistically complex and requires a lot of stakeholders. So again, with this model, the risk of delivery is transferred to external investors. So DFID and outcome funders pay on the basis of a return on their investment at the end of the day. But people will buy bonds. So we will sell to social capital investors, institutional and personal bonds in sleeping sickness. And DFID will only have to bear the costs of the payout in terms of the success of the programme. And this investment structure provides greater funding transparency about the impact of donor funding. Everybody's, DFID in particular, are just terribly worried about the Daily Mail. Anytime you have a conversation with DFID about funding for development, it's, well, suppose, what's the Daily Mail going to say about this? Well, but it's what you have to live with. So the delivery audit and outcome measurements are hardwired into the contract. Investors receive payment only after independently evaluated success. And it's this independently evaluated success which donors are very interested in now, because as we've found with the neglected tropical diseases and the impacts of mass drug administration, some social scientists have questioned the targets and the achievements that have been made in that programme, and that threatens to undermine the whole investment or 10 years of investment of DFID. So again, it's hardwiring success into
Sue, can I just clarify something there? So what you're saying is private investors put the money up front.
DFID puts the money up front. They underwrite it.
Right, but they underwrite only.
So the government underwrites the payment.
Yeah. Payment back to the investors.
Payment back to the investors.
So the investors in fact put the money up front.
Yes, they put the money up front.
If it's a success, DFID then pays. And how do you work out
they
how much?
They pay back a premium. Well, that would be based on the reduction in prevalence in this case, and this is what we're working out with DFID at the moment. I've just lost my. Because that's where you have to have this sort of independently evaluated success concept. So at the moment we're proposing that we want to take the Trypanosoma brucei from 5% down to 0.02% with certain levels of confidence. So they would pay based on the amount of success that we can reach. But that's what we have to negotiate with DFID, and that's where they're most nervous at the moment, because they want to be absolutely sure, because there's a lot of money riding on this, that
you go to the investors and say, we are expecting a 4% complete absolute risk reduction in this. If we get 4%, you'll get this much.
Yeah.
If we get a 2%, you'll get this much.
Exactly.
Okay.
Yeah. So it's quite neat,
Yeah.
and it's not something that the city are not used to. So the language, the city investors don't think there's anything wrong with this, and they think this is quite a good investment, because it's like any government bond. They're going to get their money. They're probably get their money back, if nothing else. So if all else fails, the government will give them the money if the project fails, but if the project's success, then they're paying out. But then the government have been able to sort of not spend that money really. They've been able to invest that over the 8 years in other things or in other projects. So it's a way of, if you think about the London Declaration recently, this rags to riches story, we're putting all of this investment into the programme. If you think about that, how are they going to agree to put all of these millions in when they haven't got all of these millions in? If they actually agree to fund something like this, they're deferring the cost and the payment of this actually to the next Labour government. I mean, that's the issue that's difficult to get people's heads around. You're actually promising money into the future. And Social Finance, who I'm working with in London, they have done this with the government for prisons, and their metrics are based on recidivism. So, the investors will get a return based on how many criminals go out and make you telly again next week, or something more awful. But I mean, it's a really quite a fascinating way of thinking about large sums of money, which I can't think of any other way of mobilising. Because we're talking about 40 odd million. If you're talking about rabies, you're talking roughly 300 million. Who's going to put that money up? The only people that have got that sort of money actually are us in our pension funds, or it's in the private sector. It's not in the public sector. And also, how do you get that? You could say to Gates, would like that money, but they're a bit reluctant to give that money. Nobody's willing to give that money for that. They might give you the money for a new diagnostic or something, but no one's actually really willing to pay for something which doesn't necessarily involve a rocket ship to Mars in terms of delivery.
So, but actually what you do is you defer the payment into the future, as you said.
Yeah.
So it's not that nobody is willing to pay for it, but somebody has to pay.
Yeah, eventually.
In any case, we have to pay for it.
Yeah, we have to pay for it. But then if you invest 40 million for 8 years...
The opportunity cost of that money is enormous.
Yeah.
That's the big winner for the government, is that it doesn't have to put 40 million up front. And the opportunity cost of that over 8 years is, well, probably works out as a freebie.
So, I mean, just to sort of end on a slightly grim note, that's all very positive, and I think we're going to go ahead with this, and we're starting the baseline and the design element of this project in January. And I'm excited about it for sleeping sickness because I think it offers a fantastic opportunity to get a new way of aid and practice in place. But I think that it has really good advantages for things like rabies, where you've got anything where you've got metrics. So I mean, rabies is great because your metrics are numbers of dogs vaccinated, numbers of dogs sterilised, or other sterilised better, really, dogs rather than other. And you've got a really good DALY score there that you can. And again, and it's all of these diseases are attractive to social investors because anything that causes death or disfigurement, is an attractive proposition that you want to do something about. But it does come down to sort of what do you do with these other diseases? Because every time you sort of move something out of the neglected into the dealing with it category, you've still got these other diseases here which are not so straightforward. And for the first time, actually, last year, we had a World Health Assembly resolution committing to dealing with the neglected tropical diseases, which is great. And as Margaret Chan, says, all rags to riches stories, this is all brilliant. But within this WHO 66.12, there's no mention of brucellosis. Brucellosis is a disease which is massive in the developing world. It causes major problems. It's been eliminated here in very easily here, and yet it doesn't even get a mention in the World Health Assembly resolution. How could they have forgotten to put that in? And I don't think it is forgotten or negligent. I think I don't think it is neglected. I think it's negligent that it didn't get in there in order for them to deal with that. So despite all of our rhetoric about One Health from the tripartite, if you look at the documentation that comes out of OIE and FAO, it's all brucellosis is really important. Well, if it's that important, how come WHO didn't know it's that important to get it within a World Health Assembly resolution? So that I find a little bit frustrating. So anthrax, brucellosis, bovine TB aren't within this resolution. And then yesterday I noticed that Camel tested positive for the MERS virus. So again, diseases like brucellosis and TB, or for which you can't make a really sort of major case, which have a major impact on poverty in people's lives, will just get ignored in the context of something like this, which is much more sexy and exciting. Not the camel. Although it's quite a cute camel. Thank you very much.